fracture the volar fragment, this avulsion of the, what is attached here? The volar plate. So can you call it a dislocation because the dorsal V sign is not there? Is the parallelity is maintained? Yes, the parallelity is maintained. So this is not a fracture dislocation but an avulsion of the volar chip, volar cortex, the volar attachment of the volar capsule. And therefore putting this kind of plaster is unjustified. This will unnecessarily get, that too with a metacarpophalangeal joint extended, this is invariably going to lead to a very stiff hand. And therefore the treatment of this patient is remove this thing and do a good range of motion, which we started. Avoid unnecessary immobilization. If at all you want to treat it, at least keep the MP joint flexed. And therefore this is the way. Just remove the plaster and good range of motion. What do you see here? We will not discuss the fracture of the metacarpal, fracture of the phalanx. Is it displaced? Yes, it is displaced. Is it overriding? Yes. Is it shortening? Yes. Is it angulated? Yes. Now if you put a plaster in this patient which is extending beyond, it is still keeping the joint, it is still keeping the fracture in an abnormal position. And therefore if it unites, will it be a good position? It will not be a good position. And therefore unless you reduce it, whether you treat it with a plaster or you treat it with external fixator or a K-wire plate, reduction is the mainstay of having a good range of motion. Good range of motion, good reduction, good maintenance, good physio. Now the same patient, this is how the patient presented. So he requires an osteotomy to reduce this fragment. And therefore again, to start with, what went wrong was a plaster immobilization in an unstable injury which is deformed. Fracture of the proximal phalanx, displaced, yes. Angulated, yes. Combination, yes. But it is in contact. Now this has been treated with an external fixator. What is the fixator doing? Fixator is distracting the fracture. It is preventing the natural process of healing. So this is one thing, no. What is this wire? This is not supporting anything except entering the metacarpophalangeal joint, and therefore again this is not serving any good purpose. So distraction and inadequate hold. This is holding only the one cortex. Out of two wires, one is in the joint which is useless and second wire is holding one cortex, and therefore this is unstable assembly and that too iatrogenic cause of non-union. The surgeon decides to put a plate. Now the plating is done, there is blood oozing out of this. To make it worse, surgeon has put a splint which is immobilizing the metacarpophalangeal joint in extension. And therefore, this was again a no-no. Either you put a plate, but see to it MP joint is mobilized. What is the indication for plating or immobilization? The indication for plating is so that you can move it early. But you have contradicted two principles, immobilization, mobilization. Therefore, this plate is not serving the purpose for which it is designed. It is designed so that you can move the adjacent joint freely and early, and you have countered it by putting a blocking external fixator. So to start at this stage, probably the best treatment in my hand would have been reduction, open or close, and percutaneous single K wire to get that MP joint and PIP joint moving early rather than an external fixator. At that stage, probably if I was to treat with external fixator, I will revise this wire into more proximal, see to it this fracture collapses and this joint can be moved early. Another phalanx here, and what did you see? Yes, it is displaced and requires surgery. Now what has been done? A wire has been passed from the tip going across DIP joint, PIP joint to immobilize this fracture. Now was it necessary to immobilize the DIP joint and PIP joint? This could have been done by probably putting one or maybe two K wires right across the fracture site alone, and therefore this wire was again unjustified because it prevented you from mobilizing the PIP and the DIP joint. In the end, what happened? There's some cartilage damage causing this kind of a depression, and therefore cartilage damage was the further outcome of this kind of a fixation with a very thick K wires going across a joint, which was again an avoidable situation. Now K wire has been passed from the PIP joint and it is spanning across to the metacarpophalangeal joint. So yes, good alignment apparently, but what it is doing, it is fixing the MP joint and the wire has been passed from the flexed PIP joint. What happens because of this? Mobilizing the PIP joints, it becomes extremely difficult. PIP joint contractures, MP joint contracture are the main things which give extremely poor results. To one extent, the therapist can do. After that, even they become helpless mobilizing these joints because it's painful to do it repeatedly every day for hours together. And the patient presents 6 to 8 months later, and this is the range of motion. Now, if you notice, the MP joint is fixed, PIP joints are fixed. Then there is a finger, ring finger, which is pointing to this thing, but index finger is, the fingers are not pointing, all of them are not pointing to the scaphoid. And this was all avoidable. First thing, the wire should have been passed from the base of the phalanx and not from the PIP joint. And second thing is the plaster should have been applied with MP joint flakes. If you don't put a plaster with MP joint flakes till the pain has subsided, which may be 1 day, 2 days, 3 days, 5 days, 7 days, the patient will get a stiff MP joint. So now what? Now the patient had to undergo a capsulectomy. We'll talk in the neglected trauma, capsulectomy of the metacarpophalangeal joint, volar plate release of the PIP joints here, and osteotomy for correction of the malunited fracture. So these are all things which are avoidable with only two simple things. One thing, wire passed from the base distally and immobilizing the MP joint into flex position. So again, avoidable problems. Now this was a teleconsultation by a attending surgeon. 3 K wires are passed, the finger is rotated. So what is wrong in this thing? If you see 3 K wires are located at only one location, all the 3 are located at one center, and therefore this has become a fulcrum, and instead of serving as 3 different wires, they are acting as a single wire, and therefore the whole fragment is rotating. Had these 3 K wires been parallel like this, probably it would have been nice enough. It's a long oblique fracture, and there were 3 K wires passed transversely would have been better. Leave aside the management of sagittal lateral bands which are converging from there, but this would have been stable as against a single 3 K wires converging a single intermedullary location. So what went wrong? External fixator is not an automatic device. It's not a computer generated thing that will automatically correct the displacement. Unless you correct the displacement, a fixator is going to will maintain the deformity in the present position. Therefore, the most important thing was not the fixation device. The most important thing here was the correction of the displacement. And then you put a fixator, a K wire or plate, whatever, but correction of the angulation, displacements were the most important thing. Now, can physiotherapy help? A fracture which is united in a malunion, and that too with a bony fusion, physiotherapy is not going to help. You have to intervene because the joint cannot break unless you apply a brutal force there, and therefore at one point of time these are the patient not for therapy, these are the patient at this point of time for mobilization. So in summary, out of this, avoid scissoring. Clinical examination is important, and the most important thing in phalangeal metacarpal fracture is immobilizing the MP joint in flex position. I talked in the morning in one of the talks, but if you immobilize with extension, you are heading for trouble. Mobilize early. Now, what is early? The moment the pain goes away, take out the plaster and move the finger. Second day pain, wait. Third day, wait. Fourth day, wait. Now pain is gone. Now you mobilize. But at night, put the plaster back, because in the morning after 8 hours of rest, if you don't mobilize it, in the morning it's a stiff. From 90 it goes to 80, then 70, fourth day is full extension, not moving. And therefore, in the morning, if it's not able to flex, use one of these dynamic sprints to flex the MP joint. Otherwise, gradually it will go into an extension contracture.